Anxiety disorder, epidemiology and clinical features. Introduction. Anxiety disorders cause objective distress and social impairment. Anxieties in childhood and adolescent and interfere with social, educational, and occupational functioning. Anxiety disorders is 10% of disability adjusted life years. Emotion. Brain state associated with perception of motivation is salient stimulus, a stimulus that creates a need for the organism to act. Motivation stimuli can turn to be divided into one, reward, that is, refers to a stimulus for which an organism will use effort to approach. Two, punishments, refers to a stimulus for which an organism will use effort to avoid. Fear, specific set of emotions or brain states elicited in organism when it confronts danger. Danger, any stimulus or situation capable of producing harm to organisms. Threat, act of encountering a specifically dangerous object such as predator. Different neural response result in differences in information processing and behavior. Fears versus anxiety. Fear is a specific set of emotions or brain states elicited in an organism when it confronts danger. Anxiety is elicited by signals that predict impending danger. More sustained change in brain manifests when threat is relatively removed from organism, that is in spatial or temporal context. An analog of pathologic reactions to danger in humans. Panic disorder, an acute intense attack of anxiety accompanied by feelings of impending doom is known as panic disorder. Anxiety is characterized by discrete periods of intense fear that can vary from several attacks during one day to only a few attacks during a year. Patients with panic disorder present with a number of comorbid conditions, most commonly agoraphobia, which refers to a fear of anxiety regarding places from which escape might be difficult. Epidemiology. Lifetime prevalence of panic disorder is 1 to 4%. 6-month prevalence is 0.1 to 1% and 3.1 to 6% for panic attacks. Women are 2 to 3 times more prone than men. Social factor is recent history of divorce or separation. Most common in young adult, mean age of 25 years, but both panic disorder and agoraphobia can develop at any age. Panic disorder is reported in children and adolescents. Course and prognosis. Stressful life events clustered around time of onset, anxious temperaments, and childhood trauma. Course is fluctuating. Long-term follow-up, 30 to 40% are symptom-free, 50% are sufficiently mild or not affecting life significantly. 10 to 20% continue to have significant symptoms. Relapse is as high as 50% relapse rate within 1 year of discontinuing an effective antidepressant. Depression complicates it in 40 to 80% of all patients. Alcohol and other substance dependence, 20 to 40% of all patients, and OCD may also develop. Impact on psychosocial functioning and increased rate of suicide attempts. DSM-5, recurrent unexpected panic attacks. A panic is an abrupt surge of intense fear or discomfort reaches peak within minutes, which more than or equal to 4 of the following symptoms occur. Number 1, palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath and smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesia, that is numbness or tingling sensation, derealization, feeling of unreality, or depersonalization, that is being detached from oneself, fear of losing control or going crazy, fear of dying. More than or equal to one attacks has been followed by more than one equal to one or more of one of the following. One of or both of following. Persistent concern or worry about additional panic attacks or their consequences. Two, a significant maladaptive change in behavior related to attacks. C, disturbance not attributable to physiologic effects of a substance or another medical condition. D, the disturbance is not better explained by another mental disorder. ICD-10 F41.0 panic disorder. For a definitive diagnosis, several severe attacks of autonomic anxiety should have occurred within a period of about 1 month. In circumstances where there is no objective danger, B, without being confined to known as predictable situations, C, with comparative freedom from anxiety symptoms between the attack, although the anticipatory anxiety is common. A study conducted by Srinivasa K. and Nirkal with 43 patients with panic attacks had comorbid depression. In present study, majority of panic subjects with comorbid depression had primary depression, that is 69.8%, while secondary depression was diagnosed in only 30.2%. Differential diagnosis. CNS pathologies like brain cancer or psychomotor epilepsy, medication, corticosteroids and stimulants, certain hormones, and some asthma medication, illicit stimulants and hallucinogens. Endocrinopathies, thyroid disorders or parathyroid disorders or pheochromocytoma, cardiac abnormalities, example, causes of chest pain. Then pulmonary condition, acute respiratory distress, example, asthma, pulmonary embolus. Agoraphobia, characterized by fear, that is imminent fear, or anxiety anticipated in multiple public situations, amongst crowd, or simply being out alone. In frightening or humiliating condition, they would be unable to get help or quickly escape the setting. Fear or anxiety is out of proportion with the real threat. Behavioral manifestation is avoidance, persists for more than 6 months. Epidemiology of agrophobia. Women are more prone than men. Onset peaks in the late teens to early 20s. Anxiety disorders and agoraphobia. Comorbidity rate is more than 50%. Comorbid depressive disorder is 33 to 52%. Course and prognosis. Develop panic-like symptoms, psychosomatic symptoms, mostly GI or autonomic, associated with fear or anxiety. Fear of psychosomatic symptoms cause major life dysfunction. May avoid all employment and in-person social interactions. Prognosis, agoraphobia lasting for 1 year generally remains for the next 5 years. Chronic course, best episode of depression are common during the chronic course, and more people are likely to seek help during these episodes. ICD-10 Diagnostic Criteria. All of the following criteria should be fulfilled for a definite diagnosis. A. The psychological or autonomic symptoms must be primarily manifestation of anxiety and not secondary to other symptoms such as delusions or obsessional thoughts. B. The true anxiety must be restricted to or occur only in at least two of the following situations: crowds, public places, traveling away from home, and traveling alone. C. Avoidance of phobic situation must be or have been a prominent feature. DSM-5 diagnostic criteria. A marked fear of anxiety about two or more of the following 5 situations, that is, using public transport, being in open spaces, being in enclosed spaces, standing in the line or being in a crowd, or being outside of the home alone. B. The individual fears or avoids this situation. C. That agoraphobic situation almost always provoke fear or anxiety. D. The fear or anxiety is out of proportion to the actual danger posed by the agoraphobic situation and to the socio-cultural context. These situations are avoided or endured with intense fear or anxiety. Here, the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. G. The fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, and other areas of functioning. H. If another medical condition is present, the fear, anxiety, or avoidance is excessive. I. In fear, anxiety, or avoidance is not better explained by symptom of another mental disorder. Differential diagnosis. Specific phobia, separation anxiety disorder, post-traumatic stress disorder, social anxiety disorder, obsessive compulsive disorder. Social anxiety disorder, subdivided into specific and generalized forms. Fear of more than or equal to one social situation wherein patient concerned about being harshly judged or evaluated for their performance or interpersonal interactions. Out of proportion fear that they will be shamed by experience. More than 6 months and specific social situation avoided or tolerated with significant anxiety, significant impairment in life functioning, disabling performance anxiety, severe anxiety having to meet and engage with new people, fear of doing everyday tasks in setting that is loosely described as social. Epidemiology. More common prevalent among women than men. Peak onset is early teenage years and associated with an increased risk of depressive episodes. Indian study states most common manifestation is adolescent cause avoidance of giving speeches, difficulties in coping with academics, weight concerns, having few friends, lack of intimacy with parents, and differential treatment from siblings. Female gender, family history, childhood signs of behavioral inhibition, parenting styles, increased rate of suicide attempts, significant functional impairment, hence aggressive treatment for those patients is necessary. ICD-10 diagnostic criteria. All of the following criteria should be fulfilled for a definite diagnosis. A. The psychological, behavioral, or autonomic symptoms must be primarily manifestations of anxiety and not secondary to other symptoms, such as delusions or exceptional thoughts. The anxiety must be restricted to or predominate to particular social situation. C. Phobic situation avoided whenever possible. Market fear of one or more situations where the individual is exposed to scrutiny by others may include interaction, observation, or performance situation. B. Individual fears Individual fears will act in a way or show anxiety that will lead to being negatively evaluated. C. The social situations almost always provoke anxiety. D. The social situations are avoided or endured with intense fear or anxiety. E. The fear or anxiety is out of proportion to social threat, actual threat. F. The fear or anxiety uh, or avoidance has lasted 6 months. G. The fear or anxiety or avoidance leads to significant distress or functional impairment. H. The fear or anxiety or avoidance is not due to medical condition or drugs. I. The fear or anxiety or avoidance is not due to another mental disorder. J. The fear or anxiety or avoidance is either unrelated to or excessive considering existing medical conditions. Specify performance only, fear restricted to speaking or performing in public. A. A marked and a persistent fear of one or more social situations where exposed to unfamiliar people or to possible scrutiny by others that will be humiliating or embarrassing. B. Feared situation almost invariably may take the form of panic attack. The feared social situation avoided intense anxiety and distress. The person recognizes that the fear is excessive or unreasonable. The duration over 6 months in individual under 18 years. Avoidance, anxious anticipation, or distress interferes significantly with functioning or marked distress about having a phobia. Fear or avoidance not due to a drug, medical condition, or another disorder. Fear or avoidance is primarily due to existing medical condition or mental disorder. Specify a generalized fears include most social situations. Differential diagnosis, avoidant personality disorder, agoraphobia, post-traumatic stress disorder. Specific phobia. Specific phobias are fears of specific objects, situations such as spiders or blood that go beyond the true threat of the stimulus and cause avoidance and function impairment. They are fearful nearly every time they are confronted with the phobic stimulus. Phobia should be present more than 6 months. Phobia should be present for more than 6 months. May have multiple phobic stimuli. Epidemiology. Lifetime prevalence is 6%, highest prevalence in teenage women, more prone than men. Neurological, cultural, regional, behavioral, psychodynamic, and psychosocial factors help in diagnosing. Indian study, phobia weighted prevalence values of 4.2%. Study in Uttar Pradesh in India reported that comorbidity of depression with blood injury and injection phobia was high. Culture also influences the severity and content of phobia. Asian cultures have fear related to stimulus, related to animals, ghosts, deep waters, dark, imaginary, supernatural things, and natural environment. Course. Specific phobias such as animal phobias have a unique age of onset, suggesting an untraumatic etiology, perhaps more based in evolutionary preparedness. Blood injury, illness phobia cause bradycardia and hypotension, opposed to usual tachycardia and hypertensive reaction. Genetic component is irritability, not specific for types of specific phobia. Environmental factors, cognitive factors, and conditioning plays role. Course is chronic. ICD-10. All of the following criteria should be fulfilled by a definitive diagnosis. The psychological or autonomic symptoms must be primarily manifestations of anxiety and not secondary to other symptoms such as delusions or obsessional thoughts. B. The anxiety must be restricted to presence of particular phobic object or situation. C. Phobic situation avoided whenever possible. DSM-5, a marked fear or anxiety about a specific object or situation. Example, flying, heights, animals, receiving an injection, seeing blood, etc. In children, the fear or anxiety may be expressed by crying, tantrums, freezing, or clinging. B. The phobic object or situation almost always provoke immediate fear or anxiety. C. The phobic object or situation is actively avoided or endured with intense fear or anxiety. D. The fear or anxiety is out of proportion to the actual danger posed by the specific object or situation and lead to socio-cultural context. E. The fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. F. The fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. G. The disturbance is not better explained by the symptoms of another mental disorder, including fear, anxiety, and avoidance of situations associated with panic-like symptoms or other incapacitating symptoms, as in agoraphobia. Objects or situation related to obsession, that is, as in obsessive compulsive disorder. Separation from home or attachment figures. Social situation, as in social anxiety disorder. Specify if animal, example, spiders, insects, dog. Natural environment, example, heights, storms, water. Blood injection injury, example, needles, invasive medical procedures. Situation like airplanes, elevator, and enclosed spaces. Others, example, situation that may lead to choking or vomiting in children, example, loud sounds. Differential diagnosis, post-traumatic stress disorder, panic attack or panic disorder, agoraphobia. Generalized anxiety disorder, GAD is characterized by uncontrolled worry, more days than not lasting for more than 6 months and causing significant impairment. Worry, broad spectrum, everyday life, simple daily activities, timeliness, etc. These issues concern average patients on a daily or weekly basis. GAD exaggerate likelihood and severity of stress to a point where catastrophe seems possible and imminent. These concerns can't be prioritized less important among random, more pressing matters in day-to-day active life. Inappropriate prioritization of certain anxieties has pathological effect that GAD on psychological functioning and chronicity. High rate of comorbidity cause difficulties to isolate GAD or evaluating fidelity of criteria, impairs ability to track durability, and complicates evaluation of treatment efficacy. Epidemiology, lifetime prevalence rate of 5%, beginnings in the last teens, women more common than men. High prevalence psychiatric comorbidity is prodromal or residual phase of major depression. Common comorbidities include other anxiety spectrum disorders and substance use disorders. Few GADs rare. In a community sample, the 1-year prevalence rate was approximately 3% and the lifetime prevalence was 5%. Up to 90% patients meeting criteria for GAD almost meet criteria for another axis 1 condition. 10 to 10-fold increase, 12-fold increase in risk for mood and personality disorders. Course and differential diagnosis. GAD has high constant rate of symptoms rather than the specific course seen in the more context-dependent anxiety disorders. It may have fluctuating course. Genetic associations have been noted in GAD. Childhood sexual abuse is associated with an increased incidence of GAD. GAD has increased risk for suicide attempts. Differential diagnosis, other anxiety spectrum disorders. Risk factors, chronic medical conditions, low socioeconomic situation, female sex, intolerance to uncertainty, early childhood adversity, family history. There is some heritability component of GAD. DSM-5. A. Excessive anxiety and worry, apprehension, expectation, occurring more than at least for 6 months, avoid a number of events or activities. B. The person finds it difficult to control the worry. C. The anxiety and worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms persistent for more days than not for the first 6 months. Note: only one item is required in children. Number 1, restlessness or feeling keyed up on or on edge. Number 2, being easily fatigued. 3, difficulty concentrating or mind going blank. 4, irritability. 5, muscle tension. 6, sleep disturbance. D. The focus of anxiety and worry is not confined to features of an axis 1 disorder. Example, the anxiety or worry is not about having a panic attack as in panic disorder, being embarrassed in public as in social phobia, being contaminated as in OCD, being away from home or close relatives as in separation anxiety, gaining weight as in anorexia nervosa, having multiple physical complaints as in somatization disorder, having a serious illness as in hypochondriasis, and the anxiety and worry do not occur exclusively during post-traumatic stress disorder. E. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, and other important areas of functioning. F. The disturbance is not due to direct physical effects of a substance, example, a drug of abuse or medication, or a general medical condition, example, hyperthyroidism, and doesn't occur exclusively during a mood disorder or psychotic disorder or a pervasive developmental disorder. ICD-10. Primary symptoms of anxiety most days for at least several weeks at a time, usually for several months, should involve elements of number one, apprehension, worries about future misfortunes, feeling an edge, difficulty in concentrating, etc. B. Motor tension, restlessness, fidgeting, tension, headaches, trembling, inability to relax. C. Autonomic overactivity, like lightheadedness, sweating, tachycardia or tachypnea, epigastric discomfort, dizziness, dry mouth, etc. In children, frequent need for reassurance and recurrent somatic complaints may be prominent. Must not meet the full criteria for depressive episode, phobic anxiety disorder, panic disorder, or obsessive compulsive disorder. Selective mutism, a disorder of children wherein they are unable to speak in certain social situations where a relative mutism might be expected. They are capable of speaking when at home. Lack of speech at school should be evaluated with mental health provider. It is evident that other interaction between the child and less familiar adults. And anxiety is often present as a symptom of selective mutism. Then heterogeneity in terms of comorbid social anxiety symptoms, developmental disorders, communication disorders, and many other symptom subsets. Epidemiology and differential diagnosis. Less than 1% of children have selective mutism. Age of onset is teens. It usually presents by the age 5 years. Higher prevalence in girls, twice as many in girls. Then different diagnosis, communication disorders, autism spectrum, and developmental delay. Comorbid anxiety disorders, course need not be chronic. Diagnostic criteria. A consistent failure to speak in specific social situations in which there is an expectation for speaking. Example at school, despite speaking in other situations. The disturbance interferes with education or occupational achievement or with social communication. C. The duration of the disturbance is at least 1 month, not limited to the first month of school. D. The failure to speak is not attributable to a lack of knowledge of or comfort with or the spoken language required in social situations. E. Disturbance is not better explained by communication disorder, example, childhood and fluency disorder, and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, and another psychotic disorder. Separation anxiety disorder. Patients suffer greatly when physically apart from figures of significant attachment or when anticipating periods of separation. They ponder on possibility of any harm befall them or their loved ones. This worry causes avoidance and activities that is apart from presence of attached figure. Patients fear sleep, has vigilance to reduce possibility of separation, and have nightmares regarding separation. Excessive worry is associated with somatic symptoms of anxiety, symptoms in which children should be present. Symptoms in children should be present for more than 4 weeks to meet criteria. In adult, it should be present for more than 6 months. High rate of onset is more than 18 years old. Epidemiology. Lifetime prevalence is 4.8%. 43% of these are three of these patients experiencing onset more than 18 years. Women were more prone than men. More than half of patients has remission of disorder that is less than or equal to 10 years of onset, associated with comorbid mood anxiety disorders or major depressive disorder, bipolar disorder, panic disorder, social anxiety disorder, and specific phobia. DSM-5 developmentally inappropriate and excessive anxiety concerning separation from home to whom the individual attached, as evidenced by at least 3. 1. Recurrent excessive distress when separation from home or major attachment figure. 2. Persistent and excessive worry about losing major attachment figures or about such as illness, injury, disasters, or death. 3. Persistent and excessive worry about experiencing an untoward event, example, getting lost, being kidnapped, having an accident, becoming ill. 4. Persistent reluctance or refusal to go out, away from home, to school, to work, or elsewhere because of fear of separation. 5. Persistently and excessive fear of reluctance about being alone or without major attachment figures at home or in other settings. 6. Persistent reluctance or refusal to sleep away from home or to go to sleep without being near a major attachment figure. 7. Repeated nightmares involving the theme of separation. 8. Repeated complaints of physical symptoms, example, headaches, stomach aches, nausea, vomiting, when separation from major attachment figures occurs or is anticipated. D. The fear, anxiety, or avoidance is persistent, lasting at least 4 weeks in children and adolescents, and typically 6 months or more in adults. C. The disturbance causes difficulty, significantly disturbed impairment in social, academic, occupational, or other more important areas of functioning. D. The disturbance is not better explained by another mental disorder, such as refusing to leave home because of excessive resistance to change in autism spectrum disorder, delusions or hallucination concerning separation in psychotic disorders, refusal to go outside without a trusted companion in agoraphobia, worries about ill health or other harm befalling significant others in generalized anxiety disorder, or concerns about having an illness in illness anxiety disorder. Specify if early onset, if onset occurs before the age of 6 years. Differential diagnosis, agoraphobia, social anxiety disorder, emotional experience and behaviors when alone in public overlap agoraphobia, fear in social anxiety disorders is delay in returning to loved ones, and fear in agoraphobia is secondary to unavailability of timely help or escape, occurrence of frightening or embarrassing event. Panic disorder, separation anxiety disorders might experience panic-like symptoms or even symptoms meeting full criteria for the panic attack specified here. However, panic disorder requires that some of the attacks be context independent and out of the blue, whereas panic symptom is separation anxiety disorder would have their origins in a very specific theme of separation. While fear about the well-being of a loved one could be theme in GAD, the worries of GAD involve a broader spectrum of themes and situations rather than the more circumscribed worry about separation in separation anxiety disorder. There are adult onset courses of separation anxiety disorder that seem, at least initially, to be features of a complicated bereavement process, suggesting an overlap with either post-traumatic stress disorder or complicated grief. Substance or medication-induced anxiety disorder and anxiety disorder due to another medical condition. It can manifest as either generalized or panic anxiety. There needs a temporal association between symptoms, either intoxication or withdrawal from the substance or medication. Substance or medication is known to produce these symptoms. Substances and medication includes alcohol, caffeine, cannabis, phenylcyclidine, other hallucinogen, inhalant, opioid, sedative or hypnotic or anxiolytic, amphetamine or other stimulants, cocaine and other unknown substances like hormonal, steroid, other endocrine and neuromodulatory agents. Anxiety symptoms resolve with removal of the offending agent or the resolution of withdrawal. DSM-5 substance and medication. A panic attack or anxiety is predominant in the clinical situation. B. There is evidence from the history, physical examination, or laboratory findings. 1. The symptoms of criteria A develop during or soon after substance intoxication or withdrawal or after exposure to a medication. 2. The involved substance or medication is capable of producing symptoms in criteria A. C. The disturbance is not better explained by the anxiety disorder that is not substance or medication induced. Such evidence of an independent anxiety disorder could include the following. The symptoms precede the onset of substance or medication issue. The symptoms persist for a substantial period of time, that is about 1 month, at the situation of acute withdrawal or severe intoxication, or there is other evidence suggesting the existence of independent non-substance or medication-induced anxiety disorder. Example, history of recent non-substance or medication-related episodes. D. The disturbance doesn't occur exclusively during the course of delirium. E. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. DSM-5, another medical condition. A. Panic attacks or anxiety is predominant in clinical picture. B. There is evidence from history, physical examination, or laboratory findings that the disturbance is the direct pathophysiological consequence of another medical condition. C. The disturbance is not better explained by another mental disorder. D. The disturbance does not occur exclusively during the course of delirium. E. The disturbance causes clinically significant distress or impairment in social, occupation, or other important areas of functioning. Mixed anxiety and depressive disorder. It describes patients with both anxiety and depressive symptoms who do not meet the diagnostic criteria for either an anxiety disorder or mood disorder. The combination causes functional impairment, prevalent in primary care practices and outpatient mental health clinics. Epidemiology. 2/3 of all patients with depressive symptoms have prominent anxiety symptoms. 1/3 meet the diagnostic criteria for panic disorder. 20 to 90% of all patients with panic disorder have episodes of major depressive disorder. Prevalence in general population is 10%. 50% seek primary care clinics. Conservative estimates prevalence of about 1% in general population. ICD-10 symptoms of both anxiety and depression are present, but neither set of symptoms is sufficiently severe to justify a diagnosis. When both the depressive and anxiety symptoms are present and severe enough individual diagnosis, both disorders must be recorded and this category should not be used. Some autonomic symptoms like tremor, palpitation, dry mouth, stomach churning, etc. must be present even if only intermittently. If only worry or concern is present without autonomic symptoms, this category should not be used. If symptoms that fulfill the criteria for this disorder occur in close association with significant life changes or stressful life events, category 43.2 adjustment disorders should be used. Individuals with mixture of comparatively mild symptoms are frequently seen in primary care but many more cases exist among population at large which never come to medical or psychiatric attention. Obsessive compulsive disorder, OCD has diverse group of symptoms, include intrusive thoughts, rituals, procedures, and compulsions. Recurrent obsessions or compulsions cause severe distress to the person. Obsessions or compulsions are time-consuming and interfere significantly with the person's normal routine, occupational functioning, usual social activities, or relationship. OCD, obsession, a compulsion, or both. An obsession is recurrent and intrusive thought, feeling, idea, or sensation. Compulsion is conscious, standardized, recurrent behavior such as counting, checking, or avoiding. Compulsion is a behavior carried out in an attempt to reduce the anxiety. Obsession, compulsion are ego-dystonic, that is, unwanted behavior. Completion of the compulsive act may not affect the anxiety and may even increase the anxiety. Epidemiology, lifetime prevalence in general population is 2 to 3%, 10% of outpatients in psychiatric clinics. OCD is the fourth most common psychiatric diagnosis after phobia, substance-related disorder, and major depressive disorder. Men is equal with women among adolescents, both boys more prone than girls. Mean age of onset is 20 years. Men earlier age of onset, that is 19 years than women, wherein it is 22 years. Two-thirds of affected persons has answered less than 25 years. 15% has answered more than 35 years. Can occur in adolescent or childhood. Single or more prone than married person. Difficulty maintaining a relationship. Course and prognosis. More than 50% of patients cause sudden onset of symptoms. Symptoms are secret or delayed 5 to 10 years before coming to psychiatrist. Course is variable, fluctuating, or constant. 20 to 30% has significant improvement in symptoms. 40 to 50% has moderate improvement. 20 to 40% remain ill or symptoms worsen. One-third of OCD has major depressive disorder, and suicide is a risk for all patients. Poor prognosis yielding to, rather than resisting, compulsions, childhood onset, bizarre compulsions, need for hospitalization, coexisting major depressive disorder, delusional beliefs, presence of overvalued ideas, that is, some acceptance of obsessions and compulsion, and the presence of a personality disorder like schizotypal personality disorder. Good prognosis is good social and occupational adjustment, presence of precipitating event, and episodic nature of symptoms. ICD-10. Obsessional symptoms or compulsive acts or both must be present for at least 2 successive weeks and be a source of distress or interference with functioning. The obsessional symptoms must have the following characteristic. A, they must be recognized as the individual's own thoughts or impulses. B, there must be at least one thought or act that is still resisted unsuccessfully, even though others may be present which the sufferer no longer persists. C, the thought of carrying out the act must not in itself be pleasurable. For example, simple relief of tension or anxiety is not regarded as pleasure in this sense. D, the thoughts, images, or impulses must be unpleasantly repetitive. DSM-5, presence of obsession compulsions are both 1. Recurrent and persistent thoughts, urges, images that are experienced during the disturbance and intrusive, unwanted, and that is most in individuals. The individual attempts to ignore or suppress the thoughts, urges, or images, or to neutralize them with some other thought or action, that is by performing a compulsion. Compulsions are defined by 1 and 2. Number 1, repetitive behaviors, example, hand washing, ordering, checking, or mental acts, praying, counting, repeating words silently, that the individual feels driven to perform response to an obsession or according to rules that must be applied rigidly. 2. Behaviors or mental acts are aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent or are clearly excessive.